Good morning, everyone. I, Dr. Rajani Naresh Kumar Toshniwal, resident from Dr. PDMMC Amravati, going to present a study on sonographic characterization of breast lesions. Aims and objectives: characterize and evaluate breast lesions using ultrasonography and to assess its roles in differentiating benign and malignant breast pathologies. To classify breast lesions according to Barrett's on ultrasound and to assess mammography and ultrasonographic findings whenever available. Introduction: breast cancer are the most prevalent cancer among women worldwide, causing increased mortality. There is still lack of awareness, which leads to presentation in advanced stages. Ultrasonography is a safe, readily available, and radiation free imaging modality, particularly useful in young women and in dense breast, and plays an important role in characterizing breast lesions based on mammography and internal characteristics. Mammography serves as a complementary modality, while histopathological examination remains the gold standard for diagnosis. Method: place of study Dr. PDMMC Amravati. Type of study: cross sectional observational study. Period of study was 6 months and sample size were 50 patients, and all the females with pain and lump in all age groups were included in this study. Characteristics of benign lesions: they are oval or round shaped, well circumscribed with smooth margins, smooth lobulations which are less than 3 in number, parallel to skin that is wider than tall, homogeneous, mildly hypoechoic, with posterior acoustic enhancement and minimal or peripheral vascularity. Absent or non-significant axillary lymph node supports the diagnosis. Characteristics of malignant lesions: irregular shape, ill-defined or speculated margins, microlobulations, angular or obscured margins, non-parallel that is taller than wide, markedly hypoechoic or heterogeneous ecotexture, posterior acoustic shadowing, increased central vascularity, punctate microcalcifications, and duct extensions. Results: majority of cases occurred in the age group of 20 to 40 years. Benign lesions significantly outnumbered malignant ones. The most common symptom was a palpable breast lump, often accompanied by localized pain. Most patients presented after 6 months to 1 year or more of symptom onset. Pain was frequently reported but not always proportional to the lesion severity. Some patients exhibited additional symptoms such as nipple discharge or skin changes, though less commonly. These findings underscore the importance of early detection and awareness to improve prognosis. Results in symptomatic patients. So, around 30% of the cases were normal in females, where the female presented with pain or some kind of lump like feeling in the breast. However, no lesions were detected sonographically. Benign lesions were 40% and malignant were around 30%. Now, benign lesions. Case 1, image 1.8 depicts a few well-marginated anechoic cystic lesions with posterior acoustic enhancement, suggestive of simple cyst Barrett's 2 lesion. Case 2 depicts few well-marginated, homogeneous, hyperechoic, wider than taller lesions with no internal vascularity, suggestive of lipoma Barrett's 2 lesion. Case 3 depicts a well circumscribed, heterogeneous, wider than taller lesion with mild internal vascularity, suggestive of a Barrett's 3 lesion, likely fibroadenoma. Case 4 depicts a well circumscribed, oval or round, heterogeneous lesion with posterior acoustic enhancement, no internal vascularity, characteristic multiple echogenic lines, that is, dashes and dot pattern was seen, and given a Barrett's 2 lesion on USG. On FNSE, it proved out to be a epidermoid cyst. Patient also gave history of a similar lesion on the back, and image 4.C depicts the lesion on the back region. Case 5, 5.A and 5.B depicts an oval, lobulated, well circumscribed hypoechoic lesion with few internal echogenic foci. On color Doppler, prominent internal vascularity was seen. On spectral Doppler, multiple low resistant arterial flow channels were observed, suggestive of high flow vascular lesion, likely breast hemangioma. Now moving on to suspicious malignant lesions. Case 6, image A and B depicts a large, ill-defined hypoechoic lesion which involved more than 2/4 of the breast with intense internal vascularity and axillary lymphadenopathy. Image 6.C depicts features were highly leading towards the malignant cause, a suspicious Barrett's 4A lesion. However, history of not breastfeeding from the affected breast, localized rise of temperature, and increased pain in last 7 days suggested a Barrett's 2 lesion, likely mastitis. Case 7, depicts an ill-marginated, taller than wider hypoechoic lesion with partially obscured margins, and mild internal vascularity was seen. Axillary lymphadenopathy was also present in this patient. On mammography, an ill-defined nodular high-density mass lesion with partially indistinct margins were observed. Based on USG and mammography, a final assessment of Barrett's 4B category was assigned. Case 8. Images depicts an ill-marginated, taller than wider lesion with partially obscured margin and edge shadowing with multiple stippled calcifications. Mild internal vascularity was seen and necrotic axillary lymphadenopathy was present. On mammography, an irregular high-density mass with spiculated margins was observed. Few linear fine calcifications were seen. Final assessment based on USG and mammography, a Barrett's 5 category was assigned. Discussion. Ultrasonography is ideal for dense breast and younger women. It helps differentiate solid versus cystic lesions and evaluate axillary lymph nodes. Ultrasound imaging is a widely used imaging modality in diagnosing and follow-up. The cornerstone of breast imaging is to exclude malignant lesions. Whereas mammography serves as a primary screening modality, especially in women more than 40 years, and is best for detecting microcalcifications, architectural distortions, and early cancer. Combined use enables early diagnosis, accurate differentiation, and guided biopsy with improved prognosis and reduced mortality. Architectural distortion is third most common abnormality associated with breast cancer after masses and calcification. It is often the earliest mammographic sign but carries a high false negative and false positive rates due to its subtle presentation. Malignant distortions frequently exhibit spiculated margins, long radiating lines, and microcalcifications on mammography, whereas benign distortions appears as focal irregularities without any associated mass. On ultrasonography, malignant lesions predominantly manifest as hypoechoic masses with irregular margins, posterior acoustic shadowing, and increased vascularity, while benign lesions typically present as an ill-defined isoechoic areas with absent vascular signals. Conclusion. Ultrasonograph ultrasound imaging is a highly valuable imaging method in differentiating benign from malignant lesions. It almost always predicts the benign nature of the breast lesion with excellent diagnostic accuracy. It helps to look for additional disease in the breast, image guided biopsy, and assessment of axilla. Also, integrating mammographic ultrasonic features, example speculations, complicity, hypervascularity, which improves diagnostic accuracy for breast distortions, including reducing unnecessary biopsies. Limitation: it is operator dependent and reduce specificity in dense breast and inability to assess molecular subtypes. These were the references that I used. Thank you.